Good morning and assalamu alaikum, ladies and gentlemen. My name is Aziza Ahmed. I am a fourth year medical student.
And my name is Aisha Mazhar Khan, and I am a final year medical student from Rashid Latif Medical College. We would like to welcome you all to the second plenary session of the day, focusing on a crucial and challenging area in rheumatology, vasculitis.
To begin this session, we take a great pleasure in welcoming the chairs of the session. Professor Javed Malik, consultant rheumatologist and former president of PSR from Rawalpindi. Secondly, as chair, we have Dr. Suleiman Khan, consultant rheumatologist from the United Kingdom. And joining them as co-chair is Dr. Ahmed Mirza, another reputed name in the academia. May I now request our chairpersons and co-chairs to please join us on stage.
Let's continue with the proceedings and welcome our esteemed speakers for this important session. To begin with, we have with us Dr. Asim Khurshid, consultant rheumatologist at University Hospital Dorset, NHS Foundation Trust, UK. Dr. Asim is a dedicated clinician and educator with a keen interest in systemic inflammatory diseases and their evolving management paradigms. He will be presenting an insightful talk titled Beyond the Temporal Artery, a multi-system perspective on giant cell arteritis. His talk for today is sponsored by Hirani's Pharma. Please join me in welcoming Dr. Asim Khurshid to the stage.
May I request Brigadier retired Amir Fakhr Saab, consultant rheumatologist, to join as the co-chairperson.
Thank you very much for the invitation and for asking me to present in this worthy conference. So I am Dr. Asim Khurshid. I'm basically working in the University Hospital Dorset. Here are some affiliations. The topic I was given is about giant cell arteritis beyond temporal arteries.
Giant cell.
That is something which I am very much interested in. And the reason is that there has been a huge inertia in the subject of giant cell arteritis and polymyalgia rheumatica over centuries. Giant cell arteritis was first described in 1932. So it was December 1932 in Mayo Hospital when the first two cases of temporal artery biopsy positive giant cell arteritis were presented by Horton and Beta. And that was the beginning. Before that, there had been various descriptions of giant cell arteritis by various clinicians and experts, but there was no temporal artery biopsy. So this was the first time when the temporal artery biopsy was performed. Most of the things that we practice today, they were described or suggested in the formative years of the disease. And not long after, the involvement of large vessel vasculitis was described in giant cell arteritis, and that was in 1946 by Cook. And Cook actually suggested that we perhaps have a much extended spectrum of the disease than usually visible. Following this, in 1946, finally, the temporal arteritis was accepted as an official disease. In 1950, the steroids were first used in giant cell arteritis, and that is something we had been using as a primary treatment even today and has not changed. So that is the first line treatment regardless of what happens afterwards. We luckily have many more treatments available now, including tocilizumab and upadacitinib and baricitinib, which can be used and in various scenarios in GCA, but the primary treatment still remains with glucocorticoids. Polymyalgia rheumatica, on the other hand, was described in 1951 by Barber, and it wasn't long after 1951 when they, not 1951 actually, polymyalgic symptoms in giant cell arteritis were described in 1951. In 1957, it was Barber who described polymyalgia rheumatica officially. In 1963, very interesting paper by Elastic and Barr, who described presence of positive temporal artery biopsies in patients with giant cell arteritis, in patients with isolated polymyalgia rheumatica. And Hamren in 1965 wrote that there can be large vessel involvement in polymyalgia rheumatica. So what I'm trying to say here is that there is a long history of 3 different phenotypes of the disease, and different experts at different times have been shouting that they are probably related to each other. Hamren even suggested the name polymyalgia arteritica, that polymyalgia with vasculitic involvement, and but overall the practice and the approach has not shifted in many years that we have been practicing GCA and PMR. When we look at these diseases and we try and look at various aspects of these diseases, we find that there is a huge overlap in these 3, or sometimes even with Takayasu arthritis. GCA and PMR, they share demographics, they share ethnicity, they share age groups in which these diseases present. They also share their laboratory findings, the way we approach these diseases and investigate these diseases, the biomarkers which are seen in these 2 diseases. There is a big overlap there. And so should we be thinking about combining these diseases together and looking at them as one entity, or at least a spectrum? And the concept of spectrum is not new. Right in this conference, we had been talking about many spectrums, including psoriatic disease, where we're trying to look at the disease as whole, with skin involvement, with involvement of the joints, and with other extra-articular manifestations of the disease. So I think it's time that we need to move on and try and change the trend in GCA and PMR. When we look at the pathophysiology of these diseases, we find that there are similarities both in the cellular immunity and in cytokine expression, in the immunological pathways that we come across in giant cell arteritis and polymyalgia rheumatica. And we find there is a significant overlap in the immunogenetics as well. So the whole spectrum where we are dealing with, there is an overlap, and there is similarities in genetics, in immunogenetics, in immunology, in cellular characteristics, in serology, in therapeutics, in diagnostics. Then why not try and have a broader view of these diseases? So this was a very interesting study by Cornelius van de Geest from Netherlands. It was not a very big study, but this changed the paradigm significantly. It essentially looked at a small group of patients with pure polymyalgia rheumatica, new onset, and a small group of patients with new giant cell arteritis, isolated giant cell arteritis, which was new onset, followed these patients up, and they measured different serological markers to see how they behave. And there are multiple things which are significant similarly in both diseases. Naturally, we're not saying that they are exactly the same thing. We're just saying that they are sons and daughters of the same parents, but they still look different. They still would behave different, but they're from the same family. And that is quite evident from this data, which shows that multiple serological markers, they behave absolutely in the same way, whether you are dealing with polymyalgia rheumatica or giant cell arteritis. So this is the two studies, again, looking at cellular pathology and cellular immunity and how it behaves in giant cell arteritis and polymyalgia rheumatica. Once again, when you compare the patterns of various serological, various cellular patterns, you find extreme similarity between giant cell arteritis and polymyalgia rheumatica. In both of them, there is a Th17 cell expression increased as compared to the controls, and multiple other similarities in monocyte expression, in neutrophils, in peripheral blood picture, as well as in if you look at subtypes of various cells. So this is again the main, when we look at the immunogenetics, it's the HLA-DR B1.04, which is the main allele that we are looking at, and that is what is driving or is associated essentially in giant cell arteritis, and seen increased expression is seen in polymyalgia rheumatica as well. But it doesn't stop there. If you look at further allele descriptions, you would see that there would be overlap, especially in giant cell arteritis. If you want to predict presence of polymyalgia rheumatica or vice versa, there are subgenetics that can help you deciding who is at a higher risk or who is at a low risk. But this is the main thing. The HLA-DR B104 is raised. On the left side, this was a very, very interesting study that is on the left side, which looked at multiple alleles. So HLA-DR B10405, that increases the risk of having polymyalgia rheumatica. And if you go and look at 0901, that is protective against polymyalgia rheumatica in patients with giant cell arteritis. So details of the immunogenetics can actually help in predicting which patient is going to develop which phenotype, which is precision diagnosis and precision treatment that we need to look at. Clustering studies, again, they show that there could be similarities between Takayasu arteritis and giant cell arteritis. Takayasu arteritis, the HLA-B52, which is associated, and this study shows that in patients with giant cell arteritis who are positive for HLA-B52, they have a higher chance of developing large vessel disease. And that is Takayasu arteritis, which is associated with HLA-B52, is a large vessel disease. So are we dealing with a broader spectrum with common manifestations due to minor differences in their genomes or immune response? When we look at Takayasu arteritis itself, the distribution of the disease is different. The age and the ethnicity is different. But overall, the outcomes, the way we investigate the diseases like large vessel vasculitis in elderly and large vessel vasculitis for Takayasu arteritis, which is of the younger people, is quite similar. There are certain differences in the expression, in the distribution of the disease in large vessel vasculitis and in Takayasu arteritis and temporal arteritis, which are shown in this. They are the black areas. They are primarily affected by Takayasu arteritis. The one in the red is primarily affected by cranial GCA, and the one in the blue are primarily affected by Takayasu. So the black ones is the overlap. That is the area which can be seen in either diseases very commonly. And not only that, if we look at their immunopathogenesis, if we look at the cellular immunity, if we look at the serological markers, there is significant overlap. This is at the anatomical distribution of the disease. So these studies have seen, on the left is actually a meta-analysis looking at multiple studies and seeing how we have large vessel involvement in temporal GCA, and you can see that there is quite marked involvement of diseases other than temporal artery, which is usually the focused vessel in GCA. And you can see involvement of multiple other vessels, especially the auxiliaries, the carotids and subclavians, which can lead to, which can be commonly seen in temporal arteritis. Unless you look for it, you won't find them, obviously, but if you're looking for them, it is not uncommon to find these abnormalities. Similar changes you can see on the other study published in 2003-2004, showing involvement of multiple areas, large vessels in GCA. So again, very interesting study on the left side by Al-Fishawi, published in 2023, not very long ago, looking at aortic involvement or the involvement of the large vessels in patients with giant cell arteritis and the complications that can happen basically in large vessel disease, long-term complications. And in the last cohort that they had between 2000 and 2016, they had a control group as well. And that is something which makes this study extremely useful, because you can see huge differences and a big cumulative change in the complications that can be seen in patients with GCA and PMR. So you can see the incidence is hugely different right at 5 years, and it goes up and up as we go down to 15 years. In patients with GCA, they can develop large vessel complications. So this is a summary of the data since 1975. There are various studies which have been done looking at involvement of large vessel disease in giant cell arteritis. So primary diagnosis in all these studies was giant cell arteritis or temporal arteritis, and you can see there is a marked involvement of large vessels and marked polymyalgia rheumatic PMR manifestations in almost all the studies, which is not surprising, but it is not commonly adapted when we are practicing giant cell arteritis. This is the other way, looking at the PMR GCA overlap from PMR's angle. You can get patients who have polymyalgia rheumatica about up to 20, 23, even 52%. One of the studies has shown that there could be involvement of large vessels and cranial vessels in GCA. Large vessel involvement in PMR, mainly done by the PET scan studies, show quite significant involvement of the large vessel disease in polymyalgia rheumatica. So this is my own data. So I run a rapid access GCA clinic. When I analyzed this data, I had seen about 1,000, more than 1,000, more than 1,100 referrals for GCA in our center. Of all these, the total number of diagnosed with GCA was 26.4%. And out of those 26.4%, we had 28% who had polymyalgia rheumatica at the same time. So there is about 30% overlap between GCA and PMR in this cohort. If you look at the large vessel involvement, so we can divide patients who have pure cranial GCA or pure large vessel vasculitis, or patients who have both large vessel vasculitis and giant cell arteritis. And what we find is that as we go more towards large vessel vasculitis, the incidence of polymyalgia rheumatica increases these patients. So polymyalgia rheumatica may be more associated or more prevalent as a symptom or as a presentation in patients who have large vessel disease. The polymyalgia rheumatica, as a disease, isolated polymyalgia rheumatica is not very common in Pakistan. If you see any patients, the first thing that would come to my mind is, do they have underlying large vessel vasculitis? And that is what I would like to rule out in those circumstances. So, keeping all that in mind, this was in 2023, we published something which is still controversial, and we suggested a new term. I'm partially responsible for coining this term, so if you are not happy, you can blame me. The term of GPST, or giant GCA PMR spectrum disease, that if you are seeing polymyalgia rheumatica, you need to look at possibility of giant cell arteritis in that patient and possibility of large vessel vasculitis in these patients. You need to investigate them as a single entity until you can define exactly what disease type we are dealing with. And so we are not saying that they are same diseases. We're saying they are the same spectrum. There is a difference between having the same disease and having a disease from a spectrum, or multiple diseases from a spectrum. This is the summary of the concept, that you see PMR or GCA or large vessel disease, and you take it as a one entity. Okay, we want to see, you do clinical stratification, you do laboratory stratification, and you do imaging stratification in all these patients, and you would find a predominant phenotype. So it would be predominantly GCA, predominantly polymyalgia rheumatica, or predominantly large vessel vasculitis, but there are hidden clues to other diseases or other phenotypes which may be present at the same time, and if we don't look for them, they will be missed and completely ignored. So after that, we define a specific phenotype, that what degree of overlap, or if there is any overlap or not, is there, and we stratify disease after that to take things further. This is not all in the air. This is a Delphi survey. 2 rounds have been done. This is only the first one, has been published. Huge consensus about the concept of GPST. It is not just doctors or just rheumatologists. About 50 people, which is a huge exercise for a Delphi survey, and includes patients, includes primary care physicians, includes rheumatologists. So if you adopt the concept of GPST, there are less chances of missing clinically concealed phenotypes. A better and accurate assessment can be achieved. A more comprehensive prognostication can be achieved with GCA, and you can go for a personalized treatment. I'll stop there in the interest of time, and if there are any questions later on, I'm very happy to take them. Thank you.
Thank you, Dr. Asim, for your insightful talk. Our next distinguished speaker is Professor Sami Salman, Professor of Medicine at Baghdad Medical College, Iraq. Today, he will be speaking on Behcet's disease, the great mimicker in rheumatology. Let's welcome Professor Sami Salman to share his valuable insight.
Thank you so much. Thank you. I would like to thank the PSR, whom I feel now I'm entitled to call them my family, because I've been coming on for so many years, invited by their generous hospitality and the great food. Believe me, there is nothing to compare with your food. So I'm going to talk about Behcet disease, and we have Behcet disease in Iraq. It's one of the conditions that we see it quite often. Now, this was a very dear photo to my heart last year when I was here for the conference, and this is John, and we went actually to Agagate, and we cheered for Pakistan, and actually I came back with hoarse voice, which continued until now, because so much shouting to celebrate Pakistan. Anyway, so let's start with our patients, and It was a 27-year-old. Usually they are young men that come with Behcet. And he had 1.5 year multiple painful, deep-seated general ulcers on his scrotum. Actually, it's because of the critical sort of position of these ulcers, many people are shy and they don't get treated efficiently. And I know at least one patient who developed gangrenous complication of one of his testicles, and it had to be removed. He stayed with one, and still he fathered 2 children more to his other 2 children. So it's interesting to think about it. He had right leg swelling associated with severe pain, redness, and hotness, and he was admitted to hospital with a diagnosis of deep venous thrombosis. However, the same patient started a few days later with prominent veins on his abdominal wall. 4 months later, there were multiple recurrent painful mouth ulcers. So they were late actually to appear, and this probably has made the diagnosis of Behcet a bit delayed. 6 months later, he had bilateral eye redness with a blurred vision. And this is a complication that we should always think about in patients with Behcet. He was started on prednisone 30 milligrams promptly with colchicine. This is our patient with the ulcer. You can see that it has got slightly raised margins, sort of deep with whitish background. And Y cells were a bit raised, hemoglobin a bit low, but the ESR was high. Otherwise, all the rest were normal. And this is, I hope you can actually read it. It says دائرة صحة مدينة الطب, the Department of Health in City of Medicine. And that's a radiology department. And they were talking about that they found that the superficial femoral vein and deep femoral veins were partially compressed with turbulent flow due to presence of fibrous strands, no evidence of recent thrombosis, etc. So actually he had, and this is the hypopion, not to forget to look at the eye of the patient, and you will see this is a sterile pus in the anterior chamber of the eye of the same patient. We'll talk about a second patient with Behcet, and this one, he had recurrent painful oral ulcers and later developed lower limb deep venous thrombosis, and he was put on anticoagulants. In 2019, he had severe abdominal pain, nausea, vomiting. The investigation showed long thrombus in the inferior vena cava to the common iliac vein, with thrombus in the splenic, superior, mesenteric, and portal veins. And at the time, he was put on heparin, then warfarin. On retrospect, you will see that these patients shouldn't be on anticoagulants unless you are sure 100% that they don't have pulmonary aneurysms, because they might bleed to death from the aneurysms. So in December 2021, he had left arm swelling, pain, bluish discoloration, swelling of the neck and face with a plethoric face. Venous collaterals appeared on the upper chest wall, severe headaches as a symptom with eye congestion and pain. And the Doppler study at this time showed complete thrombosis of left side neck veins, complete at the internal and external jugular veins, and partial at subclavian and brachiocephalic veins. The MRV of the brain also showed transverse sinus thrombosis. His HLA was B5, B51, B52 positive, and autoantibodies thrombophilia screen was negative. The treatment again here, that was high dose prednisolone, 60 milligrams per day, azathioprine, colchicine, and warfarin. In July 2022, his INR was 2.5. Doppler ultrasound showed improvement in that there is now 50% occlusion of the jugular veins, with, although there was thick wall and diminished blood flow. He continued with the headaches, dyspnea, and neck swelling. The CRP was high, 111. ESR is also high, 104. He was kept on an INR of 1.33. The rest of the investigations were normal. CT chest and abdomen showed superior vena cava obstruction, and this which shows clearly more on the CT. He was put on methylprednisolone 1 gram per day for 5 days, and then oral prednisolone, improved clinically, and then azathioprine was added, and again warfarin with till an INR of 2.5. 6 months follow-up, he was still in remission. Now I have to remind you of the international criteria of Behcet disease. If we have to score 4, indicating the diagnosis of Behcet. The ocular gives 2 points, genital 2 points, oral aphthosis 2 points, the skin lesions, neurologic, vascular, positive pathology, each gets 1. Scoring for diagnosed Behcet. In vascular Behcet, major cause of morbidity and mortality, pulmonary artery aneurysm gives high mortality, and we should be very careful by giving anticoagulants in these patients. We have to exclude these aneurysms. Prevalence of vascular disease is 10 to 40% of the patients. Predominantly, it is venous, and up to 90% of the cases, it is more on the venous side. The males to females is 4 to 1, with the mean age of near 30 years old, and the presenting manifestation in 27% of the cases are ulcers. The venous thrombosis, often early feature, the superior vena cava, inferior vena cava occlusion can occur, body Chiari, dural sinus thrombosis, superficial and deep vein thrombosis. As I mentioned, males are more commonly affected, 4 to 1 versus the females. More common in patients with positive pathology test. And pathology test is very simple to be done. All you need is wipe clean the forearm and just put a sterile needle and start to push it in slightly in the skin and leave, and then this will form a pustule some 24 to 48 hours later. It's more common in patients with positive pathology and ocular involvement. The vein, it is vanulitis. It is not deep, actual deep venous thrombosis. It's inflammation of the veins. And so it's not patchy, involves large segments of the vessel wall. And the thrombus is tightly adherent to the vessel wall without a free floating tail. The thrombosis is not due to a coagulation abnormality. Superior vena cava thrombosis may be latent, well tolerated, and silent, or it can be aggressive with chest pain, headaches, bilateral papilla edema, and fever. Chronic occlusion leads to prominent venous collaterals on the chest wall. These patients may present with swelling of the face, upper extremities with increased jugular venous pressure, dyspnea, and sleep apnea disorder. However, it's usually benign with efficient collateral and rarely pleural effusion and chylothorax. The chest X-ray may actually show widened mediastinum. The CT scan determines if obstruction is due to external compression or to thrombosis. MRI is done for patients with renal failure or contrast allergies. However, contrast venography is the most conclusive diagnostic tool. It defines the etiology of the obstruction. The other alternatives, radionuclide, technetium-99 venography, which is minimally invasive. On the arterial side, most commonly small vessel vasculitis, but medium and large vessel disease may also develop. Perivascular and endovascular inflammation may lead to hemorrhages, stenosis, aneurysm, thrombus formation in both arteries, veins, and varices. On the arterial side, carotid, pulmonary, aortic, iliac, femoral, and popliteal may be affected. The uncommon ones are the cerebral arteries and the renal arteries. Progression and recurrences are likely, and immunosuppressive treatment should be prompt and efficient. The pulmonary artery aneurysms involve the large proximal branches of the pulmonary arteries. They are uncommon in any disease other than Behcet. And this is sort of, the whole thing is an aneurysm here from the pulmonary artery. And actually it is so thin-walled that it is quite dangerous to give these patients anticoagulants for a deep venous thrombosis because they might rupture easily. Hemoptysis is the presenting symptom. Cough, dyspnea, fever, pleuritic pain are other presenting symptoms. A misdiagnosis of pulmonary embolism with subsequent anticoagulation can really lead to poor outcomes. So we should be very careful with these patients. Pulmonary artery aneurysm may be suspected on simple chest X-ray, but echocardiography is important, and CT angiogram, MR angiogram, plain angiogram are the usual imaging modalities. Acute myocardial infarction can occur due to coronary artery vasculitis, but is uncommon, and atherosclerosis is less common in these patients than what we find in systemic lupus. In the EULAR recommendations 2018 for the acute deep vein thrombosis, glucocorticoids and immunosuppressives such as azathioprine, cyclophosphamide, and cyclosporine A. For refractory venous thrombosis, it is recommended to give anti-TNF antibodies. Adalimumab particularly have been found very useful in these patients, but you can also use infliximab. Anticoagulants may be added provided risk of bleeding is low and coexistent pulmonary artery aneurysms are ruled out. I can't stress on this point more than that because it's too dangerous to give them anticoagulants. High-dose steroids, cyclophosphamide, anticoagulants was mentioned. If used, should be after controlling inflammation and exclusion of aneurysms. Surgery and endovascular stents are associated with high risk of complications, and they should be advised only in selected cases. I think this was my last slide, but there are also sort of, I cannot read all this slide. It tells you every part of the disease of Behcet, every manifestation, and how to deal with skin and mucosa, joints, uveitis, venous thrombosis, pulmonary aneurysm, peripheral aneurysm, CNS involvement, gastrointestinal involvement, each with how to manage. I would be glad to distribute my presentation to any of you who is willing to have it with pleasure. And thank you so much. This is the مستشفى بغداد التعليمي شعبة المفاصل, Baghdad Teaching Hospital Rheumatology Department. But this is the whole sort of medical city starting with outpatient department, the internal medicine, the surgical sort of hospital, pediatric hospital, and other hospitals, the main central labs, all in one that they call a medical city. So it's almost like a small city in the central part of Baghdad. And you can see the Tigris River. It is exactly on the river side. And I would love to invite you one day to come and visit our lovely city. Thank you so much for listening.
Thank you, Dr. Sami, for your compelling presentation. Before we move on with our next speaker, I would like to invite our chair of the session, Dr. Saleh Ishaq, to please join us on stage. Our next speaker for the session is Dr. Muddassir Shaikh, Consultant Rheumatologist at the Rheumatology Department, James Cook University Hospital, UK. He will be speaking on a very timely and clinically significant topic, ANCA vasculitis, new BSR management, guidelines. Please join me in welcoming Dr. Muddassir Shaikh to the podium.
Thank you to the PSR team for inviting me. So my topic today is to talk about the new BSR guidelines on the management of ANCA vasculitis. I'm a consultant rheumatologist with a special interest in infections in rheumatology, but I'm also involved in guideline development with the BSR. So at the moment, I'm leading the guidelines on septic arthritis, and hence I've got an interest in the guideline development as well. So this is what I'll be talking about today. I'll give you some general comments on importance of getting the diagnosis right. I'll talk about how I approach when a new guideline comes on, and I'll then give an overview on the BSR guidelines on ANCA vasculitis. I'll give a very brief overview of practice-changing vasculitis trials, and also some key considerations around immunosuppression. Now, I think my presentation will be slightly different to other presentations, because it's going to be very simple. I'm not going to show any complicated algorithms. I'm not going to show lots of evidence. And I'll talk about some personal views, little bit of philosophy, little bit of humor. And also I'll talk about principles rather than specifics, because you can read about the specifics around the guidelines yourself. So first of all, the soft diagnosis syndrome. So I think soft diagnosis is a major challenge in rheumatology. And there is a saying that non-rheumatologists underdiagnose and rheumatologists overdiagnose vasculitis. And it's obvious that non-rheumatologists are often not thinking about vasculitis, so they often underdiagnose. But at the same time, rheumatologists sometimes can be overdiagnosing vasculitis. And it's all about the mindset. And I've given you two examples here. A patient with joint symptoms who is positive for antibodies and has synovitis, you may feel very satisfying to diagnose them with rheumatoid arthritis. Whereas on the other hand, a patient with joint symptoms who hasn't got synovitis, has the antibodies, everyone thinks it's rheumatoid arthritis, but you may say, hold on, it's not rheumatoid as yet. So what I'm trying to say is that sometimes not diagnosing is the best medicine. And what I say is how to avoid this trap is, if you're not sure about a diagnosis and if the condition is not life-threatening or organ-threatening, then do not rush into making a diagnosis. You can hold fire and then reassess. Number two is, do not let a positive antibody test bully you. So we all see lots of patients who have positive antibodies and they don't necessarily have any rheumatological condition. And also there is the saying that uncertainty is safer than the wrong certainty. And I think this is very relevant in vasculitis, because often vasculitis presents with multiple symptoms. So it is very easy to overdiagnose patients with vasculitis as well. Now, guidelines are great, but sometimes if a patient reads them as well and comes to you with some specific things, then it can be quite challenging. Now, in general, guidelines are extremely useful, but you have to remember that the guidelines may not be applicable to your patient cohort due to different demographics, cost, or different patterns of disease. Secondly, many British guidelines, they are written with cost in mind as well. So you have to bear that in mind. And thirdly, not everything in guidelines is evidence-based or literature reviewed. Many of the statements in the guidelines are based on consensus. So how do I approach a new guideline? So first of all, I look at the guideline and say whether I'm practicing most of what is included in the guidelines already or not. Because generally, the evidence behind guidelines comes on 10, 15, 20 years earlier before it makes its way into the guidelines. So most of what is in the guidelines, you should already be practicing. Number two is I look at and see what are the practice-changing recommendations in the guidelines, and then are the recommendations applicable to my practice or not. So just a brief overview of ANCA-associated vasculitis classification, and there are mainly three types. So simply speaking, granulomatosis with polyangiitis is where you have ANCA vasculitis with granulomas. Microscopic polyangiitis is where you have ANCA vasculitis without granulomas, and eosinophilic granulomatosis with polyangiitis is where you have ANCA vasculitis with granulomas, but also you have asthma and eosinophilia as well. So just very simple description. Now I'll describe a case here of a 50-year-old female who presented with 3 years history of nasal crusting, bleeding, and deformed nose. She was positive for PR3 antibodies. CT scan showed septal perforation and inflammatory changes affecting the sinuses. She had a CT scan of her chest which showed inflammatory changes. So she was diagnosed with GPA with ENT and lung involvement. She had different immunosuppressants over the next 2 years. She was then admitted with diplopia, and a CT scan showed that the inflammatory mass had eroded through the orbital wall, causing diplopia affecting the extraocular muscles. And it turned out that she was using cocaine, and she was positive for cocaine in her urine. And she had also developed a hole in her palate as well. So basically, she actually had cocaine-induced vasculitis. And this case is just to say that you need to be aware of mimics of vasculitis. Cocaine-induced vasculitis can cause midline destructive lesions, and the levamisole-induced vasculitis, which is one of the substances mixed with cocaine. So the BSR guidelines this year is an update from 2014 guidelines, and it's an update, so you have to put both guidelines together if you're having a look, because the latest guidelines do not cover all the aspects which were covered in 2014 guidelines. The focus is on ENT disease, steroid sparing, and some of the newer agents. Now, first of all, it is worthwhile familiarizing yourself with some of the terminology around vasculitis, which includes active disease, and then response to treatment, remission, sustained remission, and then a relapse and refractory disease. And most of these terms are self-explanatory, but I define these terms in slightly different way. So response to me is when my registrar smiles for the first time in weeks after diagnosing someone with vasculitis. Remission is when patient does not have any signs or symptoms of vasculitis after treatment, but everyone is still too nervous to stop steroids. Sustained remission is like a mythical creature which is not often seen, but we start to whisper the word stop steroids. Relapse is when the disease is back, steroids are back, and maybe the regret of not immunosuppressing patient enough is back as well. And then refractory disease is when everyone is tired of the disease. Now, what I would say about refractory disease is that if you see someone who has refractory disease, reassess the diagnosis, make sure you're ruling out other conditions. Also, it is very common, as we all know, with rheumatological conditions that patients also develop non-inflammatory causes of their symptoms, such as fibromyalgia. So, if you are a trials geek, this is the only slide which will have about the trials and evidence. Rest of these slides are fairly straightforward. So just one slide, and I'll give you an overview of the important vasculitis trials. So the first trial is NORAM trial, which compared methotrexate with cyclophosphamide. It's about 20 years old trial, and basically the trial showed that methotrexate is as good as cyclophosphamide for non-severe disease, but relapses are more common in patients with methotrexate. And it just shows that sometimes gentle therapy isn't enough. The next one is the WAVE trial, which is a practice-changing trial which compared rituximab with cyclophosphamide for induction, and it showed that rituximab is as good as cyclophosphamide, but it also showed that rituximab is superior in relapses. And then we have rituximab, which basically proved that rituximab works with renal vasculitis as well. And then we have Mimicker, which basically proved that rituximab is superior to azathioprine for relapse prevention and maintenance. And by this time, we were getting an idea that basically it's rituximab for anything inflammatory in rheumatology. Then we have the Behcet trial, which showed that plasma exchange has no benefit in terms of preventing end-stage renal disease or death. And also that reduced steroids are as good as high-dose steroids. And this proved that less can be more sometimes. And then we have the Advocate trial, which is fairly recent, and it showed that you can use avacopan as a steroid-sparing agent, which is as good as steroids and is less toxic. So we don't have to have pushing ghosts when we are treating vasculitis. And the last one is low-VAS trial, which showed that prednisolone 60 milligram and 30 milligram are equivalent in terms of immunosuppression for vasculitis, and there are less infections with low steroid dose. Now, in terms of the vasculitis diagnosis, so diagnosis is made by clinical suspicion and ANCA positivity, but the point which the guidelines make is that you should try and get tissue diagnosis as and when you can. So that's crucial. And again, this goes down to what I suggested previously, that we should try to establish secure and robust diagnosis of these conditions as much as we can. Ruling out mimics is very crucial. So infection, malignancy, cocaine are some examples. So one of the new recommendations in this guideline is that anyone who presents with nasal disease, with vasculitis, we should screen them for cocaine. I think cocaine use is probably less common in Pakistan as compared to UK, but in UK we see a lot of patients who are using cocaine and who have, the nasal disease. And you have to remember that ANCA is often positive in patients who have cocaine-induced vasculitis. Now, in terms of general principles of treatment, so it is best to divide the condition into two types, organ or life-threatening and non-organ or non-life-threatening. And basically, there are two main phases of treatment: remission induction, where you are trying to achieve disease remission and also trying to reduce the dose to the lowest level of steroids. Maintenance, where you try to maintain the remission and come off steroids completely. Now, we should all be aware that when we are giving patients treatments such as cyclophosphamide, we need to be aware of infection screening and prophylaxis. Cyclophosphamide risks in terms of fertility for females of childbearing age, and also think about bone protection and gastric protection. So in terms of induction and maintenance, this is the algorithm from the BSR guidelines, and let's break it down a bit. So basically, all patients, when you're trying to induce a remission, you should use steroids, but you can also use avacopan or combination of the two. For organ or life-threatening disease, cyclophosphamide or rituximab are two options. Now, the BSR guideline does not suggest preference of cyclophosphamide or rituximab over each other, but if you look at the ACR guidance, they prefer rituximab as first line instead of cyclophosphamide. You can also use combination of cyclophosphamide and rituximab in severe disease. And for non-organ or life-threatening disease, you've got more options. So you can also use methotrexate or mycophenolate. Now, avacopan is finally a drug which is making steroids jealous. It's a complement inhibitor. It inhibits C5, and it can be used with or without glucocorticoids. But if you use it with steroids, then you can stop steroids around 4 weeks. So that's the advantage. Avacopan we continue for 12 months, and beyond 12 months there is no data as yet, but hopefully we will have the real life data in coming years. Now let's talk a bit more about the steroids. So steroids are the only drug we rheumatologists love, but we cannot live without them. Now, the guidelines suggest, that there is no benefit of using intravenous methylprednisolone over oral prednisolone, but that is because of absence of evidence rather than lack of evidence. The other thing I want to point out is that from the Paxivus trial and from the low-VAS trial, we saw that we can reduce steroids quickly. And if we see here, in the Paxivus trial, from week 1 to week 2, they went down directly from 60 to 30 milligram. And BSR is recommending that as well. So that to me is practice changing, that you can reduce steroids very quickly. So generally, from 60 will go down much slower, but in week 2, you can go down to 30 milligram. So that's practice changing. And then in the non-life-threatening or non-organ-threatening disease, your starting point is lower dose of steroids, around 30 milligram or so. So the point is that the guideline is suggesting that you can reduce steroids much quicker than we used to do. Now, plasmapheresis used to be a nephrologist's version of a hard reboot. And basically, when they were in doubt, they said filter it out. But not anymore, because the trials showed that plasmapheresis has very little role unless you have got severe renal involvement. So otherwise, there's no need for plasmapheresis. It used to be used more often previously. And then for maintenance treatment, the guidelines are recommending rituximab, which again is the upgrade from the previous guidelines. And the interesting thing for me is that you can use it every 4 months. So as you know, we generally use rituximab every 6 months. But if you've got very active disease, you can repeat it every 4 months. The alternatives are azathioprine, methotrexate, and mycophenolate if the above are contraindicated. So mycophenolate has taken a slightly backseat as compared to previous guidelines. The treatment should be continued for 2 to 4 years, and then patient assessed. Now, in terms of how long we should continue steroids during the maintenance period, it varies depending upon the patient, but prednisolone is like a friend who often overstays. So we often continue to give steroids longer than what we would hope for. And then for relapses, rituximab is the preferred treatment, which again is an upgrade from previous guidelines. Now, the guidelines do focus on the ENT involvement, which is quite common. And the first thing is that previously we used to say ENT localized or limited disease, but that tend to underestimate the burden of the disease. So basically they are saying avoid the term limited disease and use either ENT localized or sinonasal GPA. We need to be aware of cocaine-induced vasculitis as a mimic, and you can do a urine toxicology test, which often is positive within 72 hours of cocaine intake. Also, sinonasal GPA can be ANCA negative, and there is a role of biopsy, especially if patients are ANCA negative, or if you want to rule out other conditions such as malignancy or infections. However, often in my experience, the biopsy comes back as non-specific inflammation. So it's not always helpful. Now, the guidelines do emphasize on getting the diagnosis of eGPA right, because it's one condition which can often be missed. So basically, the trick here is that in someone who has asthma and eosinophilia, if they're ANCA positive, then think of eGPA. Now, how do we induce remission in these patients? Is very similar to a GPA with cyclophosphamide or rituximab, but for non-organ threatening disease, you've got the option of anti-IL-5 agents. So these are agents which are licensed for treatment of severe eosinophilic asthma. And they would help with eGPA as well. Now, avacopan is not part of the treatment guidelines for eGPA, but that is because of lack of evidence. Now, in summary, because vasculitis is a multisystem disease and a long-term chronic condition, patient engagement and education is of great importance. As I mentioned earlier, establishing a secure and robust diagnosis is crucial. We need to be aware of vasculitis mimics, especially cocaine-induced vasculitis when there is ENT involvement, and obviously malignancy and and infections are other mimics. It's best to use the term ENT localized rather than limited disease. In terms of what has changed from 2014 to 2025 guidelines, just to sum it up, so basically the guidelines say you can use less steroids, you can taper them quickly, and as Pexivus says, less is fine, but old habits taper slowly. Plasmapheresis is rarely needed now. Rituximab is pretty much the answer to everything now. And then avacopan is a steroid-sparing agent with good evidence behind it, and it is probably the first time a rheumatologist said no to steroids and actually meant it. And thank you very much, and I would welcome any questions.
Thank you, Dr. Muddassir. We now transition into the Q&A portion. We request our chairpersons to kindly oversee the discussion, moderate the flow of questions, and help channel the audience's queries to the speakers.
Since Dr. Muddassir is on stage, thank you for your very succinct talk and very clear-headed messages on the overview of the diagnosis. The question is from Professor Aflaq Rashid. Do ANCA levels correlate with disease activity? Or how do you place ANCA titers in your management plan?
So that's very interesting question. So the answer is yes and no. So generally what we see is that the ANCA levels would drop in most patients as you treat them. However, there's lots of evidence, lots of studies to show that they are not a reliable marker of disease response. So whilst they can give you an idea, but you shouldn't be using them as a marker of disease response.
So if somebody who has titers have gone down, and or they have negative ANCA titers, and would you use that negativity as a evidence that the disease is in remission? And if the titers come back, would you retreat them like with rituximab?
No, so we wouldn't use that as marker of remission. We would put in the overall clinical picture. So if the ANCA levels fit in with the overall clinical picture, inflammatory markers, if clinically they're improved, then yes. If the ANCA levels don't fit in with everything else, then we would ignore ANCA levels to one side.
Right. The next question from Dr. Sadat is for Dr. Asim Khurshid. And the question is there any current evidence of usage of JAK inhibitor in GCA cases? Asim? Is there any role of JAK inhibitors in GCA? That's the question.
Certainly, there is a recent study was done on upadacitinib. Upadacitinib has been approved by FDA for the treatment of giant cell arteritis, but it is not approved by other bodies at the moment. So there certainly is a role. The study, I was actually involved with that study. Quite successful results and quite convincing results with that. So in the future, it is coming, most certainly. Yeah, baricitinib has been tried as well. Upadacitinib is most likely going to be the next choice.
Thank you. From Professor Sami Salman, I just have got one question. In Behcet's, we come across cases where the oral ulcers are particularly very resistant. They do respond to anti-TNF, but at times I've seen patients where the oral ulcers are really resistant. What is your sort of approach to those patients to manage their oral ulcers?
Is it already established case of Behcet's? That's the other thing.
Established Behcet's, yes.
I haven't come across, patients who needed as far as having TNF alpha, for example, but maybe if we have exhausted all other means, all the other immune suppressants that I mentioned, then probably yes, we can resort to either adalimumab or infliximab.
Yeah, and some role of apremilast as well, isn't it?
And apremilast, yes. I agree totally. That's the other one that I didn't mention.
Yes,
yeah. Thank you.
Thank you.
So there's another question addressed to Dr. Muddassir. This is from Dr. Durkhani. If the eGPA patients get settled on rituximab, do we need to switch to a newer agent or keep continuing the rituximab?
Yes, so the guidelines suggest that you continue with rituximab for up to 2 to 4 years, and then after that you can start to think about stopping it. But what we do is that we prolong the gap between rituximab infusions. So generally we would give it every 6 months, but if patient is in remission, then we'll start to prolong it to 9 months, 12 months, and so on. So I think that would be one approach. But yes,
any tests you need to do before prolonging the duration, any IG levels or something to be sure that you don't need right now?
So we would check for immunoglobulin levels each time before each time we give rituximab infusion, and if the IgM and Ig levels are dropping, then we need to think about prolonging the duration. You can also do B lymphocyte subsets, but they are quite difficult to interpret because they would always go down with rituximab, and the problem is it's difficult to say at what level you'll be concerned. So yes, so serum immunoglobulin levels and then B lymphocyte subsets you can do. So that's what we would normally do.
Thank you.
Dr. Muddassir, it was a great presentation. You made a very complex topic into a very simple presentation. So, congratulations on that. There's a question from Dr. Ikra. What she's saying is can we ever quit giving steroids if we use avacopan? And how soon can we stop giving patients steroids if we have started patient on avacopan and methotrexate or rituximab or something like that?
So great question. So actually you can use avacopan on its own for induction. You don't need to use steroids at all. So the guidelines suggest you can use avacopan with cyclophosphamide or rituximab. But if you are going to use steroids, then the guidelines are suggesting you stop them at 4 weeks. So basically, I think it's a game changer for rheumatologists, and I think the avacopan is going to come on for more and more indications very soon. But yes, you don't need to use steroids at all if you are using avacopan. If you use steroids, then you can stop them at 4 weeks.
And avacopan, if you're using it with IV's rituximab, how soon can we stop avacopan and just rely on rituximab then?
Yeah, so avacopan, you should continue for 12 months. And the reason why it is not recommended to continue beyond 12 months is just because these studies haven't looked at avacopan beyond 12 months. So hopefully we should have that data coming on very soon. So yes, so 12 months is where we stand at the moment.
Dr. Muddassir, I just want to ask a question, like what are the side effects that we have to monitor with avacopan mostly?
So the main one, like any other immunosuppressions, is risk of infections. But the other most common one is hypertension. So patients need to have regular blood pressure monitoring because it can cause hypertension. So that's the main one.
Thank you, Dr. Muddassir Shaikh. And on behalf of the PSR, I thank you. Thank you very much. I would thank our three worthy speakers, Dr. Asim Khurshid, Dr. Sami, Salman, and Dr. Muddassir Shaikh. They highlighted the various nuances and aspects of a very complex aspect of rheumatology vasculitis, which is always a challenge in our setup to diagnose and manage with our limitations and constraints. But nevertheless, it was a very useful discussion, and I personally learned a lot, and I'm sure the audience benefited from your talks. Thank you very much.
Thank you.
Thank you to our speakers and the chairs for a thoughtful exchange. With that, I would now request the worthy chairs of the session, Professor Javed Malik, Dr. Salman Khan, and Professor Brigadier Amir Fakhr, along with Dr. Saleh Ishaq, to please come on stage to present a token of appreciation to our speakers. Our first speaker, Dr. Asim Khurshid. Our next speaker of the session, Professor Sami Salman. And last but not least, Dr. Muddassir Shaikh. I would now also request Professor Nigat Mir, Professor Kamran Hamid, and Dr. Aflaq Rashid to join the chairs on stage to present a token of appreciation to them. Our chair of this session, Professor Javed Malik. Next, we have Dr. Salia Ishaq. Next, we have Professor Brigadier Amir Fakhr. And lastly, we have Dr. Suleiman Khan. However, we would just like to add that you will be receiving your token of appreciation as the speaker of the next session. And thank you so much, sir, for being the esteemed chair for this session. Thank you. With that, we conclude this session. Thank you, everyone.